say. My background is in higher education. I've worked in several universities in this country and worked overseas in the US and in India, actually. And in many of those environments, I've worked on interprofessional learning and working, and also on really involving service users, both in research and in the learning and even the selection of health professional students. It's been predominantly with health professional students, not predominantly with medicine, though I have done a little bit with medicine as well. And it's not just us, obviously, it's also Professor Sanjiv Ahluwalia, who's not present tonight, who's the other author.
And I'm a GP in South London, where I've been for yonks, and also a teacher of law and ethics in various universities around the place, and a writer on the subject as well.
The motivation for this was really to see how we can actually develop a much more upstream approach to the development of the new health professionals coming through, so that they hit the ground running and are actually better prepared than perhaps they have been to deliver community-orientated integrated practice.
Maybe just a couple of words about Sanjiv as well, who has spoken to this forum himself before. And as Linda said, he's our co-author on the piece we're concocting. And we've had some comments from Paul already. But it'd be very interesting to hear the discussion from all of you on what we have to say. Sanjiv, as some of you might know, has been the head of the medical school at Anglia Ruskin for the last couple of years. He's just done his professorial inaugural, actually, which was a great occasion a couple of weeks ago. And he and I used to work together at HEE for many years in the School of GP, as did some of the other people here present. But what we would like to do is, in polishing up the next version of what comes before it goes to the editorial board of the JHH, in the series that we've been kicking off in the last couple of months already. And we're going to focus on the aspects of teaching and learning for the new healthcare workforce. And what are the kinds of things that we might need to consider in advancing the aims that we have within this group, but maybe also the wider aims as well. Now, this is not original, I should say, because our esteemed chairman, as opposed to our esteemed chairwoman, and I and another, about 10 years ago, put an article in the sadly now defunct London Journal of Primary Care about linking universities more closely with their localities. So that's where we are. And the next one, please. So one of the axioms, if you like, we'd like to advance is that universities have some, and HEIs in general, you might say, have some notion of societal responsibility. And that, we might argue, is particularly the case for those universities or higher institutions which are involved in training people for healthcare. And there's all that kinds of things that have happened in the last few years, the impact of COVID-19, resource issues from our political masters, social change, technology, etc., which we might argue also push this along. We know also that health inequalities have got pretty bad in the last 10 or 15 years. We know the demographic changes, certainly in Western societies that we live in. And because of these kinds of things, where particularly primary care is on the front line for this, we might suggest, and you know, we've suggested in this group before, that that has an impact on how we would wish to consider training people for their future role. And beyond that, you might say that the HEIs also have a responsibility to respond to some of the changes within society, and therefore work with the various statutory bodies that we have to deal with. The third bit of all this, if you like, is the fact that primary care, community care is, by definition, nested in the communities it serves. It's embedded, if you like. And therefore, if universities and institutions of learning are similarly embedded in their localities, then they've got to work together. Diversion. It's Sir Derek Wanless.
Oh, yeah.
You might remember he worked for the National Westminster Bank, if I remember rightly, and he was charged by Gordon Brown, I think it was. Tell me if I'm wrong, Linda. It
Yeah,
was
correct.
Gordon Brown.
Yeah.
To examine the funding aspects and other aspects of healthcare delivery. And like Aradazi, he didn't have a direct connection with the world of primary care, we might say, but he had some interesting insights. And I'll come back to that in a minute. But what you might call contextual issues that inform any debate about changing the way healthcare professionals are trained must include, we would argue, learning about the real world, the context of health and illness in communities. You could call it public health, but it's actually probably something wider than that. It's about what is sometimes rather disparagingly called softer skills, communications, ethical practice, leadership, learning about multidisciplinary team working, all of these things that probably don't get as much profile as they ought to in all the institutions that serve the training of our healthcare practitioners. Obviously, there's lots of theory behind this. Do we need to be thinking about training a different kind of healthcare practitioner who can do all of those things, as well as learn the skills of his or her individual profession? And again, we're particularly thinking of those professions that work in primary care, which has changed dramatically in its multidisciplinary aspect in the last couple of years. We've also got to think, haven't we, about the workforce difficulties we've had. You'll all be aware that the last government brought about the workforce plan that reported a couple of years ago. Would you believe they are still proposing that we need 24 consultants to 1 GP additional? Something I found quite shocking when I came across it. I'm not sure what they say about the other primary care disciplines. So these are all the drivers that we need to consider, or the influences, or the contextual aspects, you might say, that we need to work into our consideration of what it means to be a new HCP, however that's defined. The issue that Sir Derek Wanless drew our attention to in his report of 10, 12 years ago was that the NHS could not keep up with healthcare demand, however that's defined. And the date he had in mind was 2022, 2 years ago. I think we probably all would agree that in a UK context that has definitely come about. But the more subtle point he made in his report was that the only thing that would allow the system to cope with the demand is for the population to become fully engaged, his words, in taking responsibility for their own health and well-being. Now, if that's the case, one might say that it lends weight to the idea that a different kind of healthcare professional needs to be brought about. And there was commentary on the Wanless report from various people, such as Timmins and the various healthcare think tanks, that pretty much agreed with that. And it was the subject of a report by the APPG, the appropriate APPG afterwards. So the politicians got it. We would make a distinction between what Wanless and others were proposing and the idea that resource allocation should be determined on the grounds of personal responsibility for health. Mr. Cameron floated that one when he came into office in 2010. And politicians do this from time to time, I think just to see whether the balloon will fly, and it didn't. So the idea that we should allocate resources on the grounds of something other than equity actually didn't get anywhere. But there's a distinction, we might say, between that approach, ethically difficult to justify, and the idea that people should be better engaged in responsibility for their own health and well-being. So to draw all this together, these rather disparate thoughts, we're proposing a slightly different form of professional education, which requires community orientation and integrated learning to actually make it happen, embedded throughout the curriculum.
Moving to a more community-orientated integrated learning model, that's our term for it. And we know that some things are already happening, and they're happening in some very good places. But what we're also aware of is there isn't a systematic approach to this. And we also know from experience that sometimes things start well because you've got lots of very highly motivated people present within a particular set of organizations that work together. Those people move on, and sadly the thing collapses again. So it's about how do we make this more sustainable? So we're calling this COIL, community-oriented integrated learning. And the aim of COIL is to recruit, educate, and inspire all, and we're using the term primary care here, but it could apply to others as well, but we're focusing on primary care. All primary care practitioners should therefore become skilled in practicing community-orientated integrated practice. And what we felt was important was that people being developed, educated as incoming practitioners, as well as the existing workforce, but very importantly, looking upstream at the selection of students and then the education of students throughout their learning, developing in all of the professions that are impact on the delivery of care within the general practice or community practice. So we felt that it was really important fundamentally that those students were developed to have a wider social and economic, to understand the wider socio-economic context of health, and that they should be skilled and developed in working interdisciplinarily right from early on, because then they can work more effectively together on behalf of the student, of the patient, but also with the patient. And this is really important, that they are not doing unto, but working with the service user, the patient, and their families. So that means they have to be skilled and developed in communication and in some skills in coaching and mentoring, so that they can support the service user, the patients, and their families to inform themselves and to develop their own ability to look after their own health as well, so that they can make informed choices. It's about developing so that the service user is no longer the passive recipient, but is actually an active member of the team. And that means about being able to be translators of public health in its widest context, as John's indicated, and appropriate to the individual and the family, and indeed the locality, which is really important. So that they also learn to listen to and respect the patient and the family's self-knowledge, their lived experience and their own life stories, which can often be very, very important if you're trying to understand the diagnosis and how to treat somebody, but is often, not properly understood in every case, and would make a huge difference to the way in which you might work with that individual. And about being able to help people to translate health information, become health literate in the process, so that the patients can actually understand and be able to work on their own behalf. And then knowing when to lead and when to follow. Because sometimes you need to follow what the patient's saying as well as lead, or listen to another member of the interprofessional team who might have greater knowledge in the field than the individual, than one practitioner. So maybe in some instances, the physiotherapy is the best person to lead, or in some cases, the patient might be the best person to lead, but everybody can be involved. And it's how you develop that understanding and that way of communicating and developing a relationship. And then the basic principles, therefore, of COIL are: it should be ethical, because you're working with people and families, obviously. There should be an equality of partnership, and it should be relevant. Obviously, at times there'll be one practitioner that's the most important in the lead for a particular purpose, and on other occasions it might be another. But there should be equal respect, so that the patient is also part of that team wherever possible, and properly respected within the team wherever possible, or their families. The curriculum design should be really done in partnership. So thinking of general practice, it'd be very important that the curriculum isn't designed exclusively by the universities, or even with the professional and statutory bodies, though they have to be involved in, obviously, in the validation process, but also that should involve the clinical practitioners that are in this team locally, and we should have service user engagement as well, as not tokenistically, but genuinely actually listened to and involved and fully respected as a full member of the team. And I have done this, and it does work. So it's not pie in the sky, it can be done. It's very important that interprofessional learning is involved in the process, because that's how professionals learn to learn about, they learn with and about each other. And work-based learning would be really fundamental, so that the real world and indeed local issues can be the focus in these learning experiences within primary care. And then the teaching and learning methods will depend a lot on circumstances and indeed the level of the student as they're progressing through the course, but should be very much work-based, interprofessional wherever possible, and should involve things like following the service user in an experience of their particular issues, working with them, and also writing up long-term information about how they work with the service user. So there are lots of different methods. Things like interprofessional learning sets work really well in this situation, and following individual families. And there have been some really good examples of this going on in different universities and with partners around the country and indeed internationally. The challenges, and of course there are challenges. One is really developing partnership, and it can only work if everybody is on board and respects the other. And there shouldn't be a situation where one partner's left behind because the others have moved on without them, because that does not work. It's fair to say that this takes time. It does take longer, but once established, it is a really, really excellent way of working, and it really does make a difference, because that way you get it then becomes faster. It starts slow, then becomes faster, because everybody is working together. The important thing is access, of course, to service users and to the practice settings, and that's, of course, about the ethics of the process, making sure that everybody is on board and people wish to participate. And all of this takes time and isn't done. Not only is it time to build a relationship, but also there needs to be time so that these students get experience with the service users, and it isn't just a snapshot. Obviously, there's a sharing of resources, and there's something about maybe having a central resource that all parties both input to and take from, so that communication is properly networked, and indeed the information about timing, timetables, which is such a barrier if you don't manage them carefully, how you can use reusable learning resources together and develop them together to support the learning of the student. And obviously developing this so that it is, where necessary, and it will often be necessary, and be approved by the PSRBs, professional statutory bodies, and of course academic approval within universities. But all of this is doable if you bring people with you, I can assure you, because I've done it. Ethics and dynamics of the practice setting, obviously you have to be aware of that, and there are times, let's face it, even if you're just having some patients, some students into a practice setting, it's tricky. So there's nothing new in that. It's just how you work with the service users and the people in the practice setting. One of the biggest barriers, and this is based on some work of a PhD student of mine, is actually staff belief and attitudes. and their experiences. And sometimes these can be blockers, but again, it's about developing the staff and working with them. And fundamentally, to ensure it really works, you do have to have political will and support. So those are the sorts of fundamental challenges that you have to overcome in order to make this work effectively and be sustainable. So Sanjiv was very kind to bring in the sorts of things that he's doing in Anglia Ruskin. I spoke to him, was really impressed. I think when he spoke about maybe in the autumn, and I really was excited by some of the things he was talking about. So spoke to him later, and John's worked with him, and we both thought he would be able to give us some excellent examples. So he very kindly has. So his examples, we've got two that we're putting into the paper that we're publishing. And one of them is about the work for the local issue. Start with the local issue. And the local issue in East Anglia in general is that there is a real shortage of doctors locally. It's probably bad in many areas of the country, but they have a particular need. So they realize that one of the problems is people come and then they go. So the concept of developing local young people was identified, working in partnership with the local trust, the local schools, to develop something they call Next Medic. And this is a longitudinal approach working with years 8 and 9, around about 12, 13-year-old children, working them through to sixth form, year 13, and bringing them into where appropriate, and obviously it's got to be levels appropriate and age appropriate, but bringing them into practice, giving them some immersive experiences in healthcare, in primary care. And then the other thing is developing the staff so that staff work as a team, both the practice and the university, to provide mentoring and coaching for the students, and also helping them make the right A-level choices, which can be so critical in this country, perhaps more so than in the States and some other countries where people are allowed to be generalists a bit longer. And then regarding political will in this instance, HEE had been working for many years and have developed with a lot of support from the professional statutory bodies as well, this medical doctor degree apprenticeship, which means that the students will be, at the end of this course, they are offered the opportunity, if they complete the course, to go into an apprenticeship where they will be students of the University of Anglia Ruskin University, and at the same time will be earning as apprentice doctors. So this way, because they're local students, local people, they're much more likely to stay in the locality, and this will tackle a local workforce issue. So that's one example of working where it's been effective, it's made a difference, and it's actually addressing a major issue. The next one is more about the actual students already in the university, and this is about developing a longitudinal study of a family or a group of patients, where the students go into the practice over a 12-week period, and they follow a particular family or a particular individual in some cases, or individuals, along a 12-week, their journey for 12 weeks, and write it up. They work with the patient, they learn from it. And the sorts of things that they're developing as a result of that is learning about interprofessional working, learning about how to listen to the patient and communicate more effectively, and understanding some of the issues of general practice, but also whetting their appetite for general practice, which is an area which, as we know, amongst many, it has a huge workforce shortage. So again, this is another way of tackling the issues, and we think it's a good example of how you can use community-orientated integrated learning to make a difference, and hopefully a sustainable one. So that's the main body of the talk, but basically we'll just go to conclusions now. There are a number of papers that are talking about the concerns about the situation of the NHS at the moment, which is well documented, and how much is needed to change. So we're talking about really taking a fresh look to make a huge difference to the way in which students learn upstream, high, right from the get-go, from selection right the way through. So this strand continues all the way through. And we thought it was really important that we develop COIL as a new way of looking at things. We're offering it as a model for healthcare professions across the professions, and looking at how the training can be changed so that it's more focused on service users, more focused on working in practice, and actually encouraging people to think more inclusively about their community, about their patients, and about the people around the patient, so that they can become community-orientated, integrated practitioners. And that's what we'd like to offer to you.
Just one thing to add, because you've dealt with the detail fairly comprehensively, and really that's not necessarily to end on a slightly negative note, but the difficulties in a practical way of bringing multidisciplinary learners together are enormous. And I was involved in a number of projects at HEE, some of which worked and some of which have withered on the vines since. And it really requires an awful lot of effort and senior leadership support and money and organization to bring curricula together, particularly in the community. You can put learners together in a classroom without too much difficulty, but to actually get them working together and learning together in a community setting is a very tricky task. And maybe that's one of the practical aspects that we need to fix in order to do all the things that have just been said by Linda.
At Case Western Reserve University in Cleveland, Ohio, we actually have 2 medical schools connected to our university, but that's a long story. But we now have an associate provost for interprofessional education and collaborative practice. That's the title that this gentleman has, Tyler Ramsnizzle. And he's located in Central University Administration, which I think is an important part of our attempts at trying to get the health professional schools to work together. Because in my experience here and elsewhere, it's often the medical school that dominates too much. And I guess one theme to what I'm commenting is interprofessional. We're just about to undergo accreditation, and we actually had to stop our interprofessional program, despite the fact that CP1, Collaborative Practice 1, was going out into community and was having each group of 4 students, and it was nursing, medicine, dentistry, and occasionally social work, do a project with an organization out in community. The problems were that our students, particularly the medical students, didn't see the value of community work because they're trying to pass exams about anatomy and physiology, and so it's early in their career. The other thing is that medical students sometimes have the difficulty recognizing that they don't always and shouldn't be the leader of the team, depending on what the problem is that they're trying to address. So there was this issue around why should we be learning in community and sharing leadership. I want to conclude with the one comment, which is when I talk about health education, particularly in medical schools, I often say it's the faculty. The faculty are the ones that will model for students the value of collaborative practice. For example, pediatricians and geriatricians come to it more naturally than perhaps those who care for adults. But it's been a huge journey in our place, and I guess I don't want to end on a negative note, but to echo what John was saying, it ain't easy. It's a real fundamental transformation in culture, and I think it relates to a fundamental transition in what we mean really by having an academic health center rather than an academic medical center. So there you go. That's the view from Cleveland.
I wanted to build off of what Peter said, with maybe a parallel experience. So I'm currently at the University of Michigan in the School of Nursing in the Department of Systems, Population, and Leadership. And so, I was looking at the descriptions, which are fantastic. I'm really excited about your presentation, Linda and John. And I didn't see the word systems or collaboration, but I did see the words partnership. And I'm having the same experience that Peter is on the nursing side, which is nationally in the US, nursing has gone to competency-based education. And in my own department with systems, which I thought would be very exciting to be a part of looking at all these systems and how they interrelate and the integration of those systems, is headed by a statistician who thinks systems are computer networks. And so how are we to educate not just doctors, but also nurses to think in these larger, broader systems and communities if we're struggling academically to even get terms and train people together to think in these broader ways? Nursing is also struggling to do that. And my experience as an educator in the UK was the same thing, that we have students who are attracted to the health professions, sometimes coming in through public health first, and then maybe into nursing, not always going into medicine necessarily, but they all need to learn how to work together. They all need to learn how to think interprofessionally and collaboratively. And are starting from the academic out may be the hardest way to retool how our educators are thinking about bringing these people together.
The notion of role modeling, both by individual clinicians and role modeling by faculty, I think we really need to nail that as being an important issue. So we know that young learners model their seniors. And if they model interprofessional behavior that's positive, you might assume that that would have a positive learning effect for the juniors. But it's very interesting that Peter mentioned faculty as well, because if faculty doesn't do it and offer leadership to those seniors, it also ain't going to happen.
I think everybody's right that this is the tough one, but it is about getting the staff on board early and getting them involved. And some staff will get it, and some staff find it more difficult. There's no question. That was certainly one of the findings we had in a study we did on interprofessional learning and service user engagement in a higher education setting. And staff can be the gatekeepers, and if they open the gate, it works really well. So I think there is a lot to be done about staff, but there is also about leadership, isn't it? I mean, if people are led and developed, things can work. And if you've got right from the top, there's a strong emphasis on this is something that will make a difference. This is important. It does work. I've done interprofessional placements. It is more difficult in primary care, and absolutely, John and I talked about that. We've certainly done it in acute settings very successfully. And students love it, and they really enjoy it, and they get a lot out of it. And then they become your best advocates. So there's something about overcoming the naysayers and working with the willing to some extent, but also giving people the kind of experiences that help to open their ideas up. And you do have to work sometimes with the willing in these situations. I've done it with two universities, one that had the medical school, the other one that had everything else. And we had interprofessional placements. That was Sheffield and Sheffield Hallam. And we ran it as a longitudinal program. But as I said, if you don't have the sustainable political will, then when the project ends, which was a 3-year funded project, then if you don't have the political will, it goes back, and we don't progress. Now, I think it's about saying the new government coming in have an opportunity to really make fundamental change, and that it's not about them cracking the whip, but it is about them supporting.
I just want to pick up on Linda's absolutely right. It's really difficult to do anything if you don't get your professionals working together. And that's all sorts of things. It's funding streams. It's all sorts of stuff like that. It's overcoming professional prejudice. And and getting people to see that actually they can improve patient outcomes and they can get a lot more satisfaction and support working as a team. I went to a medical school, and this is 50 years ago, where a radical student union persuaded the various schools, and they weren't in universities then, there was a separate school of medicine, physiotherapy, nursing, to teach an integrated geriatric module, which I did, and I really enjoyed, and it influenced one of the really important influences on my work throughout my career. And it didn't last because I think the medical school, the doctors didn't want it. I did my GP traineeship at a health centre where the senior partner and my trainer, his sister, had campaigned tirelessly for integrated care in a health centre and had achieved some remarkable benefits. And that was also an influence. Well, it would have been, it was my training practice. And I was also influenced by the hospice movement. That was a family connection. So when it came to me being able to do something about it, team working was up there. And it was always a struggle. And it was a struggle to get other people, other providers to understand that and accept that, and to get some degree of fundamentally basic teamwork together between different us GPs and district health visiting teams and the like. It was just such a struggle. Having said that, I don't want to be too negative about it, but I want to see where you can get the wins and where you can establish yourself and get bedded in and kind of ratchet from there. And I think it's finding those moments, those people, those opportunities. We've actually heard 2 or 3 opportunities, Sheffield, Cambridge, all sorts of things going on, where you take the right steps and you get people on side, and then it becomes normal practice. And that is going to be a huge uphill task.
You can't do this if you don't. You have to have a shared developmental space to do this. And there are 2, it strikes me, very obvious shared developmental spaces that might work in the UK with the new government. One is the Streeting's idea of neighbourhood health centres, which could map onto primary care networks, which could provide a developmental space inside which universities, practitioners, people from different disciplines could work together. And the other is the homes where there is a carer, because there are 1 in 10 of the population in the UK is a carer, and they already have got relationships with various different disciplines, and they could act as a foci for multidisciplinary learning at which these things could happen.
It is important, as you say, to have a point where everybody can meet and work together and focus. That's so true. I think the other thing is getting the leadership involved, so that, it is something that institution believes in and works towards. So you do have to go in at quite a high level to start the process of getting people involved in this. That was certainly my experience, that if you went in at the right level, it is the issue was sustainability. I mean, we got it working, but as soon as the money was there for a certain length of time and everybody was doing good stuff, we had lots of interprofessional learning objects. It was very, very, I mean, we got more money on that than I can tell you, and we did use it. But you do need the political will and the leadership to make sure this happens. Otherwise, good stuff goes on in lots of good pockets, but it doesn't get, as you said, quite likely, it's important to systematic. And
it's like the bus routes, it's the number 57 buses going exactly where you want to do. You need the number 57 bus to come by. And if it doesn't know where it's going, then it ain't going to come by.
This is all very inspiring. At the moment, I'm writing an article with Francis de Kuhn on compassionate communities, which, is very much part of communities working alongside practices, and that emphasizing, which I didn't hear so much, about relationships. It's all about relationships,
Yes.
developing trusting relationships, and the interdisciplinarity. I mean, from my experience working as a GP, we were very interdisciplinary. We had weekly meetings where we met up with the social worker, the health visitor, the district nurse, all of, the people, and so that we really could work together, particularly with patients that were particularly vulnerable. So, but I think that kind of changed, didn't it? That they no longer were practice based, and I think that was one of the a mistake, really, in terms of how GPs could work. And then just to say Imperial, I mean, Artie Maney has set up coaching for students, learning how to do coaching skills, which has been revolutionary. It's incredibly popular, has really changed the mindset. There's CAPE, which I was involved with in terms... Yeah, and Elizabeth Anderson up in Leicester, she's doing great stuff. So it's kind of remembering there are all these people. Jeff Vickerts, I don't know how you pronounce him. He's at University of Westminster. I mean, I remember him working years ago, trying to get community-orientated learning at Barts, I think it was, Barts and Southern, London. So I suppose what I'm saying is that this isn't new. It's just, it hasn't got embedded. And, I mean, Alan Keller here is passionate about this idea, as you know, of it being a public health issue, a social thing, that health is, death and dying and loneliness is about all of us. We all have responsibility. Having said that, my worry is when you're talking about oneness and this idea of personal responsibility, we then get into that very individualized kind of almost neoliberal thing that you've got to look after yourself, tough titty if you don't, because we can't ignore the social determinants of health. I mean, if you're in poverty, you can't have a healthy diet. You're stressed. I mean, you just have to read Poverty Safari and these other books. So I think that mustn't get forgotten. I'm sorry, I'm being a bit passionate here because I do see this thing of individualized, you're responsible. And now there are all these apps and things that tell you what your blood pressure is and and actually, and again, we get, Tudor Hart's, the inverse care law, that the people who are taking up these things tend to be already the middle classy, well-informed, educated people. So I'm just bringing those things. So I think it's great what you're doing. The other thing is interprofessional learning, right from the start in medical school. I mean, the thing of curriculum, timetabling. I mean, I remember David Peters trying to get just a single event. I mean, not event, a seminar with nurses, medical students, and social. Always one group couldn't turn up because of a timetable. And then there was Jump was another thing that was tried. So it's a struggle. But it's interesting that Ian Kennedy, when he did the Bristol inquiry, he said one of the things that should happen is that nurses and doctors, in the undergraduates should learn together their first 2 years. That was his recommendation to improve communication, understanding, and we're going to start with the human values. We're going to start interprofessional facilitated ethics conversations so that actually nurses and doctors and so on can actually understand the different perspectives they have and the shared. And that happens in shorts rounds as well, which I'm involved in. So that's very interdisciplinary.
I'm having some difficulty making this argument small enough to manage, really. But is it true to say, very broadly speaking, that doing things that should be done in GP professional training, let's say postgraduate training, is one of the things it would have to do if the logic of these discussions were to be pursued? In which case, why is the College of General Practitioners not pursuing this way of working? Why doesn't it do that? What have I missed? What have we all missed? If the things that should be done are not being done by state agencies in this case, why are they not being done by state agencies, and what would you do about them? I think that one immediate answer is do what the post office people did. Be really, really tenacious and hang on and fight for a change situation. That means that question 3 would be, and who are the people that you need to win over and influence to achieve the change that will bring about question 2?
The answer is that they are partially, Paul and Steve. Interprofessional learning objectives exist in the RCGP curriculum for GPs, and young GPs are required to evidence it in their portfolios. I think, and I'm happy to be shot down in flames here, and this is beginning to sound a bit parochial, the problem is our regulator. The GMC pay lip service to it in good medical practice, but actually when it comes down to the detail of encouraging learning together in the way that we've been discussing, my memory is that they don't buy it and they put obstructions in the way. So I think in a way the bigger problem is actually our professional regulator. That would be my suspicion, for what it's worth.
Beliefs and ways of working of people who dominate decision-making systems. If we talk about the General Medical Council, we could talk about the Royal College of GPs, the same for nursing, the same for everybody else who's doing this sort of work. Is that right? And I get a bit insistent about is that right, because it's very easy to talk about things and say, well, it's quite difficult to do it, when quite difficult means impossible, because the underlying mechanism has not been addressed. Oh, I hate addressed as a word, I'm sorry. It hasn't been discussed even.
Let's keep this running, but James, then Peter. This is very almost to the nub of the issue in a way. Peter, James.
Thanks, Paul. I guess one of the things that we're struggling with, that there's no pushback on any of the principles. As Paquita was saying, there's not, I mean, there may be a refreshed approach, but the principles have been there for a while. What we're struggling with, and I've been listening to the words, and most have sort of prefaced what they're going to say by saying, I don't want to be negative. And the problem is, which highlights the practicalities of then putting those principles, which we would like to see happen. But how, is there a way of almost the bite size? For example, at UCLan, in our life sciences, we now have schools of medicine, dentistry, pharmacy and optometry. We have got a school of physiotherapy. A colleague and myself have brought to that, saying within the life science, why wouldn't we have a module, a special study area where there's undergraduate learning at certain times for all 4 schools? And even to get, just saying, could we create a small part of the curriculum at a moment in time, at a certain year, to bring this in, to recognize that multidisciplinary interprofessional working? My word, to get from that conversation to the practicalities, we've been talking about it for 2 years already, and we've still not moved it past great principles, but practically how do you deliver it? Because I guess, John and Linda, you are talking largely focus at undergraduate study, as opposed to, we sort of tend to, where there's enthusiasm, go when it's postgraduate. The other big problem, I've said problem now, is, and I guess we've deferred often to medical schools, is that the majority, I work closely with the University of Liverpool as well as UCLan, the majority of medics still coming in are seduced by the fact that the NHS is a hospital orientated service. No matter what we say about what Wes Streeting says about we need more community-based practice, the funding and the structure and the language is all about hospitals. So most undergraduates are coming in to be a body part doctor. There's a few who want to be a generalist, but the vast majority, and it's only during their time they might change, but over 50%. And I'm not saying we need body part doctors. We need people to fix bits and pieces. But unfortunately, I mean, even the language of the NHS, you know, I started in general practice, became primary care. Now I'm in the out of hospital sector. So we don't even talk about, we've not even got the language. You're either in the mothership or you're outside the mothership. And there's GPs and primary carers embracing this pejorative language of out of hospital care. So there's some huge barriers there. And I just wonder whether the principles of COIL absolutely sound, and the paper then describes a practical way in undergraduate teaching that brings it in an incremental approach, because there's not going to, we're not going to shift the dial to this sort of orientated teaching at any time, because as Pakita was saying, it hasn't happened to date. But maybe we can bring it in where there's universities who've got the appetite. I think Tony was mentioning 2 or 3 of them, and they've got life sciences schools where you could bring in modules that starts the process, shines the light, and recognizes the vast majority of care, the low tech, low complex care to a point, is in the community, and that's where you get your illness. The principles can be described in the paper in the practicalities, the deliverables, because that's the big step.
Hey, just before we come to Peter, can I ask you, in your view, is that phenomenon you've just described the expectations of new students or the expectations of the teachers inside the universities, or whatever?
I think there's a blend of both. The other thing, just an aside, which is something I've noticed for lots of students as they're going through medical school, that's what I'm attached to mainly, is they've all got exit plans.
Ooh.
You know, they've exit plans from taking an undergraduate course but not becoming a doctor. You know, if things go wrong. So there's again, it's just another part of the environmental issue of bringing in a new type of training, which I don't think you could push back on the principles, but I just wonder how practically you can start it, because if we don't, we'll be talking about high-level principles, but the practicality of a clear module, a curriculum that's designed for life sciences across specialties. I didn't mention nursing either, that at certain moments in time, they can come together as part of their courses.
Paul, you said maybe we have to start earlier. And I think in our intergenerational public schools, we're trying to create a sense of what health is in the population at large at a young age. I mean, we were talking about pre-teen almost. That's a huge undertaking, because I do think it's the expectations that medicine creates for people in their lives in community that focuses on the body part. We've got a pill for this kind of approach, or the whole way we educate about health. And for me, climate change, climate crisis is going to be a force. Mother Nature is going to show us the importance of local community and of taking responsibility for our own health. I agree with this notion that this is not an individual lifestyle issue as much as it is a community issue. When who was it? Laura mentioned that nursing in the United States is going to competency based assessments. I also thought of Tony's or somebody's comment about regulatory bodies. When I heard nursing was going to competencies, I was talking to one of the deans of the nursing school and said, "Oh no, this sounds like trouble to me." Why? Because I don't want to argue for incompetent nurses or incompetent doctors, but I do want to argue for, can you capture everything about what it means to be a healer in something that is an exam format? Then I went to the medical education retreat and I heard they're going to competency bases. And it's all out of the AMC, the American Association of Medical Colleges. And in those bureaucracies, you got problems with people who have built their careers around standard models, and they don't tend to foster innovation. And finally, let me say one thing that I think is more germane to the United States than the UK. But in the UK, it's all a question of what gets reimbursed and who gets the money. And we obviously don't give enough to primary care, but we also don't give enough to the kind of team model. Although I suspect the incentives in the NHS for who gets what part of resources is also an issue. It's just not as bad as it is in the States. So that.
I finished med school about 4 years ago, and patient communication was fairly new on the curriculum when I finished my education, but interdisciplinary collaboration was definitely not any part of it whatsoever. And I very much recognize what Peter said about the whole culture difference and the sort of interdisciplinary. In Danish, we say gnidning. It kind of means like we rub against each other, but in a negative way. And I think that should it be up to me, the earlier in the process of medical school, the better to get that to be part of the curriculum, simply to change the culture and to that way get a language forward that we need to work together about a patient-centered care instead of sort of against each other. For myself was that I took an additional course, which is something my university hospital offered, where you can actually take a nursing course and then take shifts as a nursing assistant. I don't know if you have the same in the UK, but I did it for the money because it was great night shifts and you were a poor student. But the best thing I ever got out of it was my communication skills. There is a notable difference between having to talk to patients before you get out as a junior doctor and haven't. And obviously, we have nurses who then go to med school and they always are a step ahead, but it made such a difference. It really did. And you could clearly tell who had talked to patients before and who haven't. So I'd say to, in any way, shape or form, to get a such stay in a hospital setting, in a general practice setting, I'd say we are forced through general practice, but I know that in the UK you're not. So if you could, in some way, shape or form, maybe get a few weeks in where you have to actually see patients, interact with them, perhaps drive out with the healthcare personnel and really experience that interdisciplinary collaboration we do on an everyday basis, I think that would be so beneficial.
I just wanted to go back in my training to a course that I took first as an undergraduate nurse in 1998, and then as a graduate nurse practitioner in 2002, and then as a faculty member. We had an interdisciplinary course that had social workers and occupational therapists and nurses and doctors and pharmacists and dentists. And we did a community-based project across the entire semester in a rural community to actually run a dental bus. But what I wanted to add to that, we also had law students in the course, and the experience completely changed my approach. I had to work extra hard to find time in my curriculum, both as a faculty member and as a student, to squeeze it into the competency base that we call it now. But even then, the curriculum's fixed. Your role is fixed. It's designed. And then we all battle out to get this one piece into the curriculum. So now we call it teamworking or interprofessional. But that course, and what I wanted to highlight in it was truly experiential. And it wasn't just that you were coming in as a nurse. I was working on a dental bus driving around a rural county. And so I wasn't there as a nurse. I was there as a human working with other humans, trying to figure out how to experience and deliver care to a community on their terms. And so if we think of it as interprofessional and it's just teams coming in with their roles, we've missed the advantage we have by calling it competency. If the competency is relationship-based communication and assessment in an experiential learning experience with other members of the community, then I'm learning from the key informant, who happens to be the old lady who runs the local store, who lets us park in her grocery store parking lot, is helpful to the learning. And so I think I just want to come back to, it includes policymakers. It includes the funding. The funding for that program came from the Department of Aging, which cared about taking care of elders. And they built the program around that. So how do we include policymakers in the ground up? How do we include community members in the planning so that we can get the funding to the communities that need, and then not start the definition from our roles and our titles and whether or not we're participating, but actually the service that's being provided and how everybody's a part of that and informing that. And then the learning organization isn't just one organization, hospital or out of hospital. The learning organization is the community. The funding is coming from the policymakers who are participating. And in the ideal world, and I've seen pockets of this happen, both in London as well as in rural North Carolina, where I was, that we have to include the community members and the policymakers to in the design and the delivery, in the co-design and co-delivery of these kinds of trainings. Otherwise, medicine will always be dominant.
I mean, in the UK, children are expected to go straight from school to university. So they work really, really, really hard to do their A-levels, and then you launch straight into sort of 6 or whatever years it is of medicine. How about requiring them to have a gap year, inside which they are required to do a kind of an action research project based in some community setting of their choice, anywhere in the world, or a set of them, in order for them to deliberately understand the essence of what we're talking about? Any mileage in that kind of, because what I'm observing, because I do a little bit of work with children in my son's school, is that they are desperate to please. They want to get, they have to get A stars because they can't get into medical school without it, and they want to do the right thing and shine and perform ever so well on everything, be the best of the best, and they're actually terrified of actually really encountering how nasty the world can be.
I might be able to contribute something. I started off getting really pessimistic about it, and then aligning myself with Peter, who saw climate change as bringing the whole pack of cards down. But I've come around. So first of all, I think to be sustainable, one of the things that I heard you say is people have been trying for years to get joined up thinking. And there was this sort of wail from some people said, why can't we make it happen? But maybe there's a limit to how much joined up thinking you can actually get. So my first point is, I think to be sustainable, these changes have to be from bottom up, really grassroots. We've heard it so many times, but it's very hard to make it happen. Second point is that you mentioned yourself, Paul, the idea of involving secondary school children in something. That sounds crazy, Eddie, but actually in Ireland we have I don't know if it's unique, but it's very unusual. We have a transition year. So in the middle of their education, where all of the different subjects are being, all of the teachers of the different topics are protecting their particular patch. Suddenly, towards with 2 more years to go of their education, there's a complete timeout. They take the entire secondary school children, take the entire year out, and they do transition year. And they would do things like you described. It's not done very well, but it could be it is a model for you to consider.
It is difficult, but I have actually done it. And you're absolutely right, Vikita, if you're still there. It is about relationship building, very fundamentally. But we actually got to the point, trust me, we really did, where we had shared competencies which were approved by the professional and statutory bodies, fact. And it was truly interprofessional. You do need to have people from the top. I know the bottoms up is really important, Craig, I agree with you. But you also have to have the high hegians, as we say in Scotland, supporting you. And I mentioned the importance of political will as well. We actually got loads of funding because at that time the Department for Education was really interested in interprofessional learning. But what we were talking about, John and I, wasn't just interprofessional learning, though a lot of people have focused on that aspect. We've been talking about getting people to deliver community-orientated, integrated practice, COIP. That's what we've been talking about. And what we've been discussing is how we actually get practitioners upstream. I was really interested. Thank you so much for Catherine, for saying it should be early, because there was a big debate when we were first doing it. And it was about, I was the one that said it's got to start early. And that's what we did. And we actually got the professional bodies, and we are talking quite a few, not just one or two, to agree to this. It was sanctioned by them. The other thing we had interprofessional placements where the quality rating was for all the professions. So once the professional area had been approved, it was approved for all of them. That's also a fact. We used the elastic walls we cannot have in universities, sadly, nor the timetable that is absolutely going to fit. I totally agree. That's why we had reusable learning objects, and we had a group developing that with patient voice, patient talking heads, people involved in it. So it can be done. The problem was it wasn't sustained once things had moved on. It lasted really well, but it wasn't sustained. And why it wasn't sustained, in my opinion, is because it wasn't recognized by the next high people coming in, you know. So you do need to have that kind of support from the top, otherwise it won't work. But it wasn't easy. I'll tell you another thing. I had staff in interprofessional offices. We had a new building, and I said they've all got to be mixed up. We don't want not having the physios in one place and the nurses in another. We had interprofessional office, and you know what? I used to take people around that building, and I'd say just go in and ask them what they think about it, and the staff loved it. So you do have to sometimes give people a chance to try things, and they absolutely loved it. So it is doable, but you do have to work at it really hard, and you have to be tenacious. And you know, the people who supported it most were the students and the patients. What's that all about? Yeah.
We've got 1 minute left.
How important it is to bring it up, to mention it. We spent our first 3 years in Denmark in the bachelor's degree right next to chiropractic. We take all the same courses together, and I'm ashamed to say that I can't name the name of one of them. I wasn't aware how bad it was until I was teaching a course for both the medical students and the chiropractors together, how divided they not sit or like they mix well enough in the room, but the way they engage is different. And I think that had it been brought up a topic of how important this is to really see and value our collaboration with each other, I think it would really be seen as a positive thing.
This is so big. I'm bemused as how we go forward. But there's an element that we're too compartmentalized, I suppose, because Linda has done some super work, obviously, within the educational service. But did these people go on and do this stuff when they worked? I mean, there's an issue here, and maybe it's too short a time. My only view is that if you're going to do something like this, like in some of the successful international public health things, is you've got to hit it at all levels, which people have said already. So you've got to get some policy people interested, and you've got to get some people who are working interested, and it's going to be slow to even get those people working in new ways. But that's the only way. And the trouble is, when we do it like that, who is going to keep that spirit going? That's a big issue. We as an organization meet monthly and enjoy it, but we don't have that leadership function. Maybe we should, maybe we shouldn't. But it has to be at multi-levels with likely people to get an even notice. I'll digress a bit. I'm on the periphery of a small group of people who think Lucy Letby might be innocent. I'll just throw that in, because the evidence that was presented to the case was a disgrace. But there's only been a handful of people who are building up and got some MPs on board. So even at that fairly specific thing, we might get some action. To do something as broad as this means that we've got to work hard at getting some people who are interested at different levels. but who will coordinate and keep the energy going? Otherwise, it will die. And that's a real big issue for radical groups because they have lots of great theoretical options. And then it's a good talking shop stuff. But the connection to do things is much more fundamental. So, yes, we've got to. And is that a role for us? I don't know. It's a big task, but there has got to be somebody to sustain this. Somebody out there. I mean, it'd be interesting to know what James thought, because when he did that great program on the public health inequalities with the primary care networks, did they talk of such things? It would be interesting to see if they did. Even that's a group that you might think would be more positive about this new way of working. So there's a lot of stuff to do. It is possible with Labour now in power and West Streeting having had this almost Pauline conversion to primary and community services, that whether he might want to feed in with some of his Labour people about community and clinical working together. All of these things have got to be explored, but that takes a lot of organising and a coherent group of people who are born to do that leadership work.
Just to say that this was all done under the Blair government.
Oh, well,
there you go. Just say.
By the school. I wonder if there's a case to be made by asking a university to expect their medical students, those who are having a gap year or even requiring to have a gap year, to do something of this kind in that year supported by their school. And Aradazi's review of the NHS supporting that kind of thinking, precisely in order for people at an early stage to be able to understand the complexity of what we're talking about and the need for collaborative practice.
Yeah, I think it's just making the distinction between, I think, what COIL is trying to do, focused on the learning at an early stage of your career as an undergraduate, and then the difference which we've been doing with this multi-professional teams, the team-based learning once you've actually qualified, and then starting to deliver your specialty in a different, your specialised area in a different way. So I think there's a distinction. John can correct me on that, and I'm sure Linda is, but the team-based approach to care, where as we're doing with the Complete Care Community Programme, I think is a different entity to the teaching in undergraduates of the community orientated learning. So for some of the most complex areas of care, which can't be the traditional team of, have one of these, one doctor, one nurse, one physio, and as opposed to, no, you've got to build the workforce in a very different way than we've done for team-based care before.
Was given that you were ahead of the game in terms of looking at health inequalities rather than biomedical medicine, was there a hunger? That's all I was asking. Even amongst this leading edge, was there hunger for a new way of educating each other? That's what because even though we're talking about undergraduates and things, we're not. We're talking about a life learning experience where some people come late to these thoughts. And how do they get help? So I just wondered if in that relatively fertile ground that you had maybe created looking at health inequalities, was there any hunger for this new way of thinking about how they were trained and so on?
No, we've not really explored it to even assess whether there's a hunger. I think
But nobody volunteered anything like this?
No.
What we were talking about, John and I, is upstream developing this kind of view. It doesn't have to be the only thing they learn, clearly, but it is part of the learning culture, as somebody said, and I think it might have been Catherine. It's about the change in culture from the very get-go. So I'd just be interested to see if there's a group or maybe a couple of groups that might have a particular area that would be relevant to COIL or COIP.